That's fine. Thank you very much. We're now being recorded and live streamed. So, welcome back to this meeting of Integration Joint Board, and we'll resume business at item 9, which is Aberdeenshire Health and Social Care Partnerships Annual Performance Report for the year 25-26. It's recommended that we approve the final draft report and agree that the Chief Officer can publish the annual performance report on the Health and Social Care Partnership website, and for the Chief Officer to share the report with the Chief Executive of Aberdeenshire Council and NHS Grampian. And I'd like to invite Shona Campbell, please, to introduce the report, and then we'll take any comments or questions. Thank you.
Thank you, Chair, and good morning, members. So I am pleased to introduce Aberdeenshire Health and Social Care Partnership's Annual Performance Report for 2025-26. As members will be aware, the production of an annual performance report is a statutory requirement. This report provides a comprehensive and transparent account of how we have planned and delivered services over the past year in line with our statutory responsibilities. It also reflects the reality of the environment we've been operating in, which is one of rising demand, increasing complexity of need, and continued financial and workforce pressures. Despite these challenges, the report demonstrates that we have maintained delivery of a wide range of essential services for the people of Aberdeenshire, supported by a partnership budget of around 485 million, while continuing to progress improvement and transformation. Within the report, we highlight key areas of progress during the year. We have continued to deliver against the 5 strategic priorities set out in our 2020 to 2025 strategic plan, with clear progress across engagement, prevention and early intervention, reshaping care, tackling inequalities in public protection, and ensuring the effective use of resources. At the same time, we have begun the transition to our new strategic plan for 2025 to 2035, which places a strong emphasis on prevention and early intervention, alongside a continued focus on supporting those with the greatest and most complex needs. A key theme throughout the year has been our commitment to shifting the balance of care. We have seen tangible progress in prevention and early intervention, including increased support for unpaid carers, continued development of self-directed support, and testing innovative approaches such as community appointment days to improve access to support and empower people to better manage their own well-being. Alongside this, we have taken forward service redesign, including the development of new community-based dementia support models, expansion of technology-enabled care, and the continued rollout of digital and telecare solutions, all aimed at supporting people to live independently and reducing reliance on hospital-based care. Engagement and co-production have remained central to our approach. We have undertaken extensive engagement with communities, staff and partners to inform both service reviews and the development of our new strategic plan. And this ensures that our services continue to be shaped by the people who use them. The report also highlights the scale and importance of our work in tackling inequalities and protecting vulnerable people. Demand in areas such as adult support and protection remains high, and we have continued to strengthen multi-agency collaboration and quality assurance to ensure safe, effective and person-centred responses. Finally, I would emphasise that this report reflects the commitment, professionalism and resilience of our workforce and the strength of our partnerships across Aberdeenshire. Members will note that some national indicator data was not available at the time of writing due to publication timelines from Public Health Scotland. These sections will be updated with a supporting data annex ahead of final publication. So this paper presents the final draft of the report and seeks the board's approval to publish it online and to share with our partner organisations. It's a key component of our governance and assurance framework, enabling us to demonstrate accountability, reflect on progress and identify areas for further improvement. Thank you, and I'm happy to take any questions.
Well, thank you very much indeed for the report and for your introduction, Shona. I would just like to invite members, please, if you'd like to indicate if you have any questions or comments. Dr. Paramjoti Shantini, please.
Thank you, Chair. So firstly to say thank you for the report. It reads really well and, really congratulate the Health and Social Care Partnership on all the work that's been undertaken. I suppose it's a comment really on the prevention, and I think there's a lot of good work in there, and I take the point that sometimes our data systems, especially where they're dependent on getting data from Public Health Scotland, may not follow the timelines of, there is a data lag for reporting. But I just wonder whether, maybe going forward, we can also recognise the breadth of work that's going on in Aberdeenshire around things like breastfeeding, healthy weight management, smoking cessation, vaccinations and screening, because these are all really important preventative actions that are actually going and, doing really well. And actually contributing quite a lot to keeping people out of hospital and keeping people healthy across Aberdeenshire. Thank you.
Yes, thank you, Shantini. Yeah, happy to take that feedback on board, and something that we'll make sure that we bring through more strongly in the next report. Thank you.
Okay, thank you very much. And it's Professor, sorry, I miscalled. So thank you for that. Councillor Grant, Maury, please.
Thank you, Chair, and thanks for introducing the report, Shona, and just to add my words of thanks for it. It's very clearly laid out in a great exposition of the work of the partnership over the last year. Just three questions about aspects I picked up. One, page 74, in the section about suicide prevention, where it mentions demand was up by 64% from 24 to 25. From 24-25 to 25-26, and it does mention referrals. Is that the primary reason for the increase in the demand, or other aspects in there as well? Just to pick up as well, page 85, 7 performance analysis. We've had reference also to the data that's still to come forward. There's a reference to completeness levels for NHS Grampian data from August 24 onwards are also much lower than in previous years. Therefore, figures in the update would likely change significantly. And I was just looking for a bit of background as to why these completeness levels are still quite low, since we're talking about 2 years almost previously. And just finally, page 93 in the iMatters staff survey, looking at the average responses. Obviously the ones in yellow are the ones that stick out for questions, and these tend to centre on confidence and involvement in decision-making, perceptions of that, and I was just wondering if there was any lessons we could learn from that going forward. Thank you.
Thank you. So I might have to ask colleagues for some support with the details around specific services. And if I might, on your second question around the performance analysis and the completeness of the data, I might bring in Angela MacLeod, who I think is joining us online to support with answering that question.
Welcome, Angela.
Thank you, Chair, and thank you, Councillor Grant. Yes, I can't comment directly on the reasons for the data completeness levels. I think with regard to the NHS Grampian data, but that's not necessarily unique to NHS Grampian. I know for a number of NHS boards it can be an issue that in terms of Public Health Scotland, they have to manage that, and that is a reason for the data not being quite available for public release just as yet. But I know from other communications that there is active work underway to increase those completeness levels within NHS Grampian, a lot of work underway to do that retrospectively as well. So I think we can have confidence that data completeness levels are continually improving. But it is just one of the caveats that we add to the data in terms of the analysis that we can draw on it, just for absolute transparency. In relation to the data being released by Public Health Scotland, there will be a further publication on the 7th of July. So it's from that date that we will be able to delve into the data with more confidence, particularly in terms of understanding our performance against other areas, and being able to do some of that national benchmarking and comparison, and in particular to understand our performance against the first 10 core integration indicators and the outcome indicators, which will have just been refreshed following a repeat of the national survey in the last year, and they allow us to understand more about people's experiences of the care and services they receive from their health and social care partnership. So that's why we felt it was really important to just hang on for that next data release on the 7th of July, and we'll be able to issue a more fuller and comprehensive analysis of our performance from there.
Thank you, Angela. And I'm just going to bring Alex in, if I might, to answer your question on suicide prevention, and then I'll come back to you around iMatter.
Okay, thank you, Shona, and thank you, Councillor Murray. I think, really just in terms of suicide prevention and the distress brief intervention, there's been a huge amount of national work that has been done, to really drive that forward, not just as well nationally, also in Aberdeenshire, so we're seeing lots more awareness across our partners of referral routes and pathways into services. But I think we also have to acknowledge, that we do have a number of people impacted, across our area, by, for example, the cost of living. It's one of our mental health and learning disability service managers that are strategic lead on this, so I can go and get some more detail. But I think what we are doing is we're really publicising, that this service is available, and I think people are getting more, proactive about asking for help as well when they need it, which is really encouraging, and great work amongst partners around our pathways.
Thank you. And just in response to your question around iMatter, Murray, you're right. I think in every year we receive similar feedback from staff around involvement in decisions and around visibility of senior leadership within the organisation. And what I can say is we've just undertaken the survey again this year and have our reports for the 2026-2027 cycle, and we're working on that as a leadership team on a plan for improvement around that. Thank you.
Thank you all very much indeed. Murray, would you like to come back?
No, just to thank everyone for their responses. Very helpful. Thank you.
Thank you very much. Joyce Duncan, thank you.
Thanks. I just wanted to comment on the clarity and readability of the report. I think it's a very readable piece of work, which is quite unusual when it's something as formal as this. So well done for that. I wondered about the Enhanced Dementia Support Team and the work that they're doing, and will that be impacted by the Grampian Mental Health Bed-Based Review and Tier 4, or is it two completely separate things? Thanks.
I'll bring Alex in to respond. Thank you.
Thank you, Shona, and thank you, Joyce, for the question. I think this is something that we're definitely going to have to look at within the older adult mental health part of the bed-based review in the Tier 4. Obviously, when we moved to the Enhanced Dementia Service in South Aberdeenshire, that's been based on the Newcastle model. We do have 2 dementia assessment units, one in Inverurie and one in Fraserburgh, but we really need to work, as part of the cross-system strategic delivery team around, what we need those units to do, or do we actually maybe start disinvesting in something to create more enhanced community pathways. But we're really watching what's going on in South very, very closely, and that's also feeding into the cross-system strategic delivery team and the bed-based review. So it's a case of watch this space, but we're doing a lot of modelling at the moment, Joyce.
That's great. Thank you very much for the clarity on that.
Thank you very much. Dr. Blackwell, Colette, please.
Thank you. I would just like to say, first of all, that I totally agree with Joyce. This was a very easy read, and whilst acknowledging that there's still challenges faced, I think it was a very positive report. So well done to everyone involved. My question relates specifically to the community appointment days. We know that they are a much more effective use of system resources, and to Shantini's point earlier about keeping people out of hospital and providing support in communities, I wonder to what extent there are plans in Aberdeenshire Health and Social Care Partnership to have more community appointment days.
Thank you, Colette. So, yeah, we have had 2 community appointment days to date in Aberdeenshire. Very different approach to both, with involvement of different teams. So, I think at the moment we're just really testing and learning from those. We have taken a paper through the Community Planning Partnership about progressing community appointment days as a whole system, and the opportunities that exist there. So that would be the route through which we would be planning to develop that approach in Aberdeenshire.
That's really helpful. Thank you. I look forward to hearing more about it. Thank you.
I think maybe when there are plans and there are dates, if members of the IGB could be advised, and maybe they'd want to attend, to visit. Yep. So if could just make a note of that, please, that where you've got dates coming through the Community Planning Partnership conversations, if all members could be advised of those, Shona, and then folks can pop along and see what's happening. So thank you for that. Councillor Keating, David, please.
It's me. Gosh, I thought it was John. Obviously, we've really all shared out the task because we're all asking questions about different sections. And so my questions are around section 5, the GURFE section. We're a pathfinder area for something that's an established process. So I'm just wondering what we're pathfinding on. But then it goes on to talk about Grampian Hope, which we have talked about here before, which then almost as GURFE is a subsection of looking at a bunch of other things as well. And I just wonder how it all fits together. But then finally, I think, and I'd actually put this as a motto for the IJB, the reinforcing the idea that sustainable change is most effective when it builds on existing strengths. And I think that's something we should always carry with us, because I think that's really important. And it looks as though Hope is looking to declutter the landscape. Again, I'm a fan of that. But what does that mean, given how does that fit back to what we're doing in GURFE and all the other things that attended this Hope conference? I guess, Shona, if you can give me a wee bit of an understanding of, and then what happens, because I love decluttering. I just wonder what we're actually going to declutter. Thank you. That's me.
I think I can come in on the point around the Hope approach and how that will declutter the landscape. I think there was a recognition from a group of practitioners and leaders across Grampian that we had a number of approaches that were all trying to achieve the same thing. So Hope doesn't stand, it's not an acronym for anything. I think it was just that they felt all of these different approaches brought kind of a hopeful and positive approach to how we would deliver services across Grampian and could achieve that together. So that's how they're trying to declutter the landscape, is to bring all of those approaches together in one collaborative and take work forward together. Sorry, I can bring Lee in around the points on GURFE as well.
Okay, then I'll come back with my E.
Yeah, thank you. Can you just repeat the question? I think I understood it around GURFE.
I guess I'm not sure I understood it, which is, it says we're a pathfinder for area, but as long as I've been in the IGB, I've heard us discussing GURFE. So what are we pathfinding, given I thought it was an established process? And our report actually says it's an established process. So what are we pathfinding?
Yeah, so as a health and social care partnership, I guess we're my microphone is on. We are completely committed to GURFE, which is getting it right for everyone, and that's got to be about the foundation of how we deliver services, how we communicate with those that need our services, how we reduce duplication, how we prevent the passing people on from one person to another, etc. So making that whole journey as streamlined as it possibly can be, so we can embrace that, and we can do that as part of our core and key principles of how we work alongside individuals in our community. However, Scottish Government also asked for a number of partnerships to consider being pathfinders, to see if there was a way to model pathways that would reduce that duplication. So they were looking for us to test how we may
enhance communication, how we may prevent the number of handovers, how we may have more of a one-stop shop in terms of people requiring a particular service and not having to go to A for something, B for something, and C for something. So the Pathfinder element was about trying to explore some of that could then be shared nationally. But it's not doing anything different to what we would do on a day-to-day basis, but it's about how we implement that GIRFE approach right across Scotland.
Excellent answer as always. I think it still comes back to my E. Well, actually, that sounds really good, but then Shauna's explanation on the HOPE, which I get it, it's not an acronym, it's just it's the word. But there's a whole bunch of different things which are similar, adjacent, possibly even trying to sit in the same area. And it may just be the way I heard it, Shauna, but it almost sounded like, and then all the individual initiatives will sit down together and they'll all cooperate. Whereas to me, there's something more that says, if there's a common what you're doing underneath it, you don't need 6 initiatives to do it, you just need one. And I think I kind of heard that from you in this, what you're talking about, the pathfinding, which means I look forward to somebody telling me we've stopped something, not because it's a bad thing, but because the good things it does are being done in another badge. And is that what you might hope as well, Lee?
Yeah, absolutely. I mean, I think for me, GIRFE's got to be about how we are working much more collaboratively rather than siloed. And that's therefore got to reduce the pressure on the workload, because we aren't sending people to 3-4 different places to get different types of interventions. So GIRFE's got to keep the person at the centre of it. That's what it has to be about. So if we get that right, we should reduce duplication, which should enable us to realign where we put the work and the pressure, address the pressures, I suppose. I think the final thing about the HOPE conference, I suppose for me, I think the HOPE conference is just a really good opportunity to bring people together and remind us that actually this is about the people that we deliver services to. And sometimes that can get a little bit lost when we are following process and we're making savings and we are working under significant pressure. So HOPE is about lifting our heads back up, recognizing where the journey that we've been on and the progress that we've made, to ensure that we take a much more person-centered approach, to ensure that people who receive our services are shaping them, and that again we remind ourselves of how important that is, because we can't get this right from a professional perspective. So the HOPE conference brings that, shines that light and reminds us of the work that we've done and where we need to get to really embed GIRFE, as opposed to it being about doing the collaboration, because that's got to take place before we even get into a conference.
Well, that's fine. I add I add together your 2 sets of responses, and I think I'm very assured. I look forward to hearing what decluttering actually occurs at some point in the future. Thank you.
Thank you all very much indeed. Dr. Tomlinson, John, please.
Okay, thank you. Just first of all, to highlight at paragraph 7.1 of the report, page 85 of the pack, where we're talking about further improvements to strengthen visibility of performance. The IJB did set up a short life working group, and that's still in process. And so that will come back to a future IJB. And I think that's going to be a welcome further development of visibility around performance across the work. We have the annual report, but something more regular to the IJB will be showing progress for us in our scrutiny. So it's just wanted to highlight that element there. One point would be, I agree with what colleagues have said about the presentation of the report and for public consumption. I would like in future to help the public understand the scale of what we do. We've got the money, 485 million sounds a lot of money on its own. I think going forward, it'd be useful if there's some sort of scale put on the volumes of support that's provided into the community. So it's just a suggestion on having read this, and be interested if officers feel that would be useful to do as well. And the other aspect will be on the benchmarking going forward. There's reference to being able to go in and see that. I think it will be helpful for the IJB going forward to have a bit of commentary back in future covering reports, just on what the trends are and where Aberdeenshire sits in relation to, because there's challenges right across the Scotland, all the IJBs, and just seeing a bit more visibility on that. But we are benchmarking well, which is testament to the ongoing work that everybody's been doing. So just a couple of suggestions there. Thank you.
Thank you very much. And is the benchmarking trend line something that you would incorporate into the performance management presentation?
Yeah, I think we can certainly look at that. Thank you.
Okay, thank you very much indeed. Angie, please.
Thank you, Chair. I've attended regularly the community engagement days, and I'd like to say how excellent they are and how far they go in actually in enabling people in the community actually to understand more about what the partnership does and what it offers. I just have one comment to make, in that I think that the publicity for the community engagement day could be improved. I think the information about where they're being held isn't heard in the community, and I know that because I've spoken to people in Stonehaven about them. And I wonder if it could be possible for the information to go out to places like schools, for example, the community centres, some of the shops in the area, because actually we're missing a huge group of people in the community because they're only going in certain places. Thank you, Chair.
Thanks, Angie. Is that the community action days you were specifically, the action day you were specifically referring to?
The community action days and the community engagement
and
days.
the engagement.
Yeah.
Joe, from a communications point of view, do you have any comment?
We do try to widely publicise all of our engagement events. I think the community action days are slightly different in that they are targeting a specific group of people. With the engagement, so the most recent community appointment day in Stonehaven, we did send out information to schools, and we sent out posters to community centres, etc. We are reliant on people sharing that for us, because we don't have people that can go around and put them up specifically. But it was really nice to see. It was a very well attended event, that one, and hopefully we can learn from that for the future.
Thank you both very much indeed. So I absolutely note the points, Angie, and we'll try and get as wide a circulation as possible of the information. So thank you for that. Thank you, Joe. Dr. Tomlinson, John, do you want to come back in? Oh, legacy hand. Okay, that's fine. Thank you. I don't see any other indications then, colleagues. So again, I think lots of comments have been made, and I think the board would absolutely endorse them about the presentation of the report and the work that has gone into developing this report. It does give you quite a flavour of what actually does happen within the partnership, but I'm sure there are lots of other areas, and Shantini's mentioned some of those that may want to be brought to the fore in future. So yeah, thank you, Angie. I think it's really important to acknowledge that, and it does give a flavour, I think, of what you do as a partnership, but and in partnership with others. So really, thank you very much indeed for the report and for the work that has gone into it across all of the service. But thank you, Shona, and to your team. And this will be now published. Well, we need to agree the recommendations. Can we agree those, please?
Agreed.
Thank you. And Harriet, as part of the minute, you'll have picked up some of the points and comments that have been made, so we don't lose those as well. So thank you for that. So we've agreed the recommendations. It will now appear on the website, and full council will go on to consider it in September, I would think. usually comes through full council, and NHS Grampian will get a copy too, and will deal with that at the board level. So thank you all very much indeed. Item 10 on our agenda is a report entitled Afford Clinic, and this is identifying a property which is not going to be required to deliver services, and we've been asked to declare the building surplus and to initiate NHS Grampian's process for repurposing or disposal. Are members minded to agree the recommendations, or do you wish to hear officers? We can agree? Then that is agreed. So thank you that. So we note that the clinic's no longer required, and we have agreed to declare it surplus, and that will go back to NHS Grampian for their asset management approach. Thank you very much indeed for that. Takes us then to item 11, which is the proposed relocation of the Macduff vaccination service. And again, there's been community engagement involved with this as well, and members have got feedback within your pack. We are being recommended to approve the relocation of the vaccination service from the site of the previous Macduff GP practice in Macduff to Chalmers Hospital in Banff. And subject to that approval, we agree to declare the Macduff premises as being surplus to our requirement as a health and social care partnership. But I will ask Alex Pirrie, please, our partnership manager for North, to introduce the report. Alex, thank you.
Thank you, Chair, and good morning, members. So the paper before the IJB today is to seek approval to progress the proposed move of the vaccination service from the current site of the previous Macduff GP practice premises to the Chalmers Hospital in Banff. Section 3 of the report outlines the IJB risks that this proposal relates to. So with regards to the IJB risk 2608, the proposed changes will support the partnership to ensure the safe, efficient and effective delivery of the service from a fit-for-purpose premises within our resources available. In relation to IJB risk 1590, engagement has been undertaken with affected communities and stakeholders to ensure that the impacts of the proposed move are fully considered and inform the IJB's decision making today. Section 4 of the report provides the background to the proposal. So the vaccination clinic in Macduff was established in 2021 to help support the safe and effective delivery of the COVID-19 vaccinations within very short timescales that were required at the time. However, this was an understanding that it would be a temporary arrangement. The partnership needs to provide vaccination services from premises that are clinically suitable, sustainable and make the best use of available space and resources. Section 5 of the report outlines the context to the vaccination service provision and the proposed relocation, together with the engagement process that has been followed and the outcomes from that engagement. Paragraph 5.2 in the report outlines what is currently provided from the premises in Macduff, the population coverage of the clinics and the total number of patients within the geographical area covered by the clinic per vaccination programme. I should highlight that this is based on data for 2025. Prior to the vaccination clinic being established in Macduff in 2021, the building had been vacant for some time and it was in the process of being prepared for sale by NHS Grampian as part of their estate's rationalisation programme. Work was carried out to bring the building to a condition for clinical use for the vaccination programme. However, in its current condition, the building is not sustainable or suitable for expanding services. So, for example, the heating and hot water system has reached the end of its life and it's no longer reliable. Relocating the service to Chalmers Hospital in Banff will enable a more efficient use of resources by streamlining service delivery in one central location, providing a fit-for-purpose, safe and quality clinical environment for the delivery of our healthcare services. It will also give us greater flexibility for future service developments and improvements within our available resources. We must recognise, however, that any proposed change may have an impact on some people. Therefore, we have undertaken engagement so that members of the community have had the opportunity to tell us what the move might mean for them. A short survey was issued on the online engagement platform, which ran from the 13th of May till the 3rd of June this year, and it was actively promoted across social media channels and via community councils and elected members to enable as wide a representation as possible from communities affected to give their views on the proposal. So this feedback and the feedback obtained from an informal session with the Banff and Buchan Area Committee has helped to inform two integrated impact assessments which accompany the report to the IJB today. These are attached as appendices 1 and 2. The engagement and IIA process has been designed taking into consideration the scale of the service change proposed and the population impacted. The engagement summary describes the efforts undertaken to promote awareness of the online survey and to support and encourage responses, including a mechanism for people to complete paper copies where they preferred. Notwithstanding the response rate, it is the content of the issues and the impacts identified that provides the important basis on which the IIAs have been shaped, and the IJB must show due consideration to the impacts raised by people from the communities affected. Section 6 of the report outlines the implications with regards to equality, staffing and finance. With regards to equalities, Appendix 1 is the IIA for the proposed clinic move, and Appendix 2 is the IIA in relation to the proposal to cease providing health and social care services from the current premises at Macduff and declare the building surplus to requirements. As noted in section 6.1 of the report, there are a total of 8 positive impacts associated with the first proposal and 7 positive impacts associated with the second proposal. There are 8 negative impacts identified as part of both activities, and of these, none have been mitigated and 8 cannot be satisfactorily mitigated thus far. However, it is important to highlight that in response to whether or not an impact can be mitigated, the IIA system only permits a response of either yes or no, rather than partially mitigated. It is the view of officers and member of the Short Life Working Group that was established to support planning and preparations for the work required, that the impacts can, within the resources available to us, be reasonably mitigated and can reduce impacts on people, but we do understand that these cannot wholly be mitigated for every single person impacted. Concerns from roads officers have also been identified through feedback from our area manager colleague. Roads concerns were a significant theme in the engagement process, specifically in relation to Chalmers Hospital only. However, officers in the Health and Social Care Partnership are continuing to engage with colleagues in our roads team, and they have made some really helpful suggestions about further mitigations. The information that IIA reflects the themes and impacts by the respondents. The most common theme relates to parking and access at Chalmers Hospital, and the second key theme relates to increased travel time, transport difficulty and costs. Some concern was noted about further loss of services for Macduff, and this is acknowledged in the IIA. Chair, it's important to highlight to members that the questionnaire used in the engagement process sought to assess the impact that the proposed changes would have on respondents in a scale ranging from no or little impact to a very big impact. A small group of respondents supported the proposal or said it would have little or no positive, it would have little impact or positive impact for them. Some comments noted that consolidating services in one site made sense, that Chalmers Hospital was closer or more convenient for them, or that having a wider range of services together would be more efficient. The report does reflect these comments, and that for a number of people from Banff who currently travel to Macduff for their vaccinations, they will be able to access the vaccination centre closer to home. Therefore, alternative travel options such as walking may be suitable. However, we must also show due regard to the negative impacts identified by other respondents, where mitigations require to be identified and implemented as far as reasonably possible. As can be seen from section 6.3 in the report, there are no direct staffing implications associated with the proposed move. The proposal does not create any additional unfunded pressure on the delegated budget. With regards to the financial implications, based on the current annual running cost of the Macduff site, the proposal is expected to release up to £27,972 of premises-related costs from the vaccination service budget. One-off non-recurrent costs associated with the vaccination move are estimated at approximately £2,000 and will be met again from the vaccination service budget. No other material financial implications have been identified. So to conclude, Chair, the proposal would see the vaccination service move from a temporary and no longer a sustainable site to a more fit-for-purpose clinical premises at Chalmers Hospital. However, it is recognised that the change will create concerns for some people, particularly in relation to parking, travel and local access. These issues have been considered through the engagement and integrated impact assessments. On balance, the proposal is recommended by officers because it supports a continued safe and effective delivery of the vaccination service from fit-for-purpose clinical premises, and making better use of available resources, and officers will continue to work collaboratively to identify and implement mitigations as far as reasonably possible, with ongoing monitoring to reduce adverse impacts. Chair, I should also highlight that I'm joined today by my colleagues Fiona Stephen, Location Manager for Banff, and Steph Anthony, our Operational Lead Nurse for our CTAC and vaccination services, who may be able to support with detail any question in relation to any questions from members regarding either the hospital site itself in Banff or the vaccination service if required, but we're happy to take any questions. Thank you, Chair.
Well, thank you very much indeed for your report and indeed the overview. I think it's really helpful to hear, and I'm sure members may want to hear a bit more about the engagement with the road service, but I'm preempting probably what Councillor Cassie might want to say. Ross.
You're not, Chair, but thank you for bringing me in anyway.
Happy to help.
Yes. Right. I'm not here to lob hand grenades around. I'm here to put across some of the comments that have been made to me by the folk of Macduff. You mentioned the people in Banff would be happier with it going to Chalmers because it will be closer to home and they'll be able to walk. The last census, Banff and Macduff had a population difference of 40. I think it was in favour of Macduff. So there's a greater population going to have to move now. I totally get and understand the clinically suitable location of Chalmers. As has been highlighted, parking in that area is very difficult with the hospital and the services that it runs at the moment, as well as the MIU when you get an appointment, and the GP service, which has amalgamated a number of other services within it when GPs in Gardenston, etc., closed down, and then Macduff moved across there as well. So parking is at a premium, so the roads concerns are good. There is mention of bus transportation. Now, yes, I would agree, there is a bus. And yes, people can move appointments. However, if that appointment isn't moved for any reason because there isn't availability or something, you could end up with getting the town service bus, which gets you to your appointment 50 minutes early. You have your appointment, you've missed the next bus going back, you're in Banff for 3 hours as opposed to, or for a couple of hours, as opposed to going in and coming back. Now, I do know that there is a possibility of Banffshire Partnership picking up that slack because I'm led to believe that those discussions are taking place. But it was predominantly those with mobility issues, don't have vehicles, and getting the buses is difficult in itself. They've raised concerns that it's all been moved away, and they related it to the place policies that the council have and the NHS have as well. And what they're seeing is everything being sucked from the Macduff area into Banff. Now, that could very well be folk saying everything goes to Banff. On this occasion, I tend to agree with them, however. But I'm not opposed to this because of the clinically suitable building that Chalmers is compared to the thing. And I guess I'll just have to drive myself instead of walking to the end of the road to the clinic. So it's more comments than questions, Chair. Thank you.
No, those are appreciated, Councillor Cassie. Thank you very much indeed for that. And we'll probably come back, or we may come back to the issue around the roads. So thank you for that. Councillor Lang-Gordon, please.
Thanks, Chair. Yeah, it was just to follow on for what Councillor Cassie was saying there. Just some concerns on the parking issues, because it's not just the GP practice and the hospital parking. There's the residential parking on the surrounding streets as well. I'm just wondering what the officer's feedback was on that. And when the vaccination centre does move across to Banff, is it going to be keeping its name Macduff vaccination clinic being in Banff, because I noticed that when Macduff Medical Practice moved across, it's still called Macduff Medical Practice. I mean, it's not entirely confusing at all. Just those couple of points, that's all. Thanks.
Alex, do you have any further information around the discussion with roads, please? And then we can maybe refer back to the naming of the service. Thanks.
Yes, thank you, Chair, and thank you very much, Councillor Lang, and yourself, Councillor Cassie. So we have had some discussions with our Rose colleagues, and they I guess are in agreement of what we're planning to put in place to try and do further mitigation, and I can go into a bit about that in a wee bit differently in a wee minute around the appointment system to alleviate as much pressure as possible. So I think what we're actually planning to do, and Fiona Stephen is in the call, but the appointments, will really be managed, to ensure an appropriate flow of patients through the hospital. Have to highlight that we're already experiencing providing a large number of clinics at peak vaccination times. Appointments will be offered at a variety of different times, including where there is low to or zero usage by other clinics. So, for example, from 5 p.m. to 8 p.m. We'll also have the option of possibly Saturday clinics as well. We also do use pop-up clinics at peak times. So, for example, in Portsoy, it is in our gift to coordinate and control the frequency of appointments, and our appointments are carefully organised to ensure that the correct level of patient numbers and flow through the hospital has been managed. There will also be supportive signage around the hospital to direct people to the correct area. And in terms of car parking, we are going to do all we can to mitigate any car parking issues. But I think, just to highlight from speaking with Rose that they have really also made some helpful suggestions, around highlighting in our appointment letters, that we can vary our appointments, highlighting, the transport options, the options of Saturday appointments. And I also should say that the vaccination appointments are for a short time, in terms of what it takes to have an injection. So therefore, we wouldn't expect patients to be attending the hospital for a long period of time. Rhodes colleagues have also highlighted that there is limited parking in the existing location in Macduff, and thus far they haven't felt it been necessary to make any road changes as a result of the vaccinations working out of the current premises, and they've also highlighted that the existing building in Macduff is quite close to a school.
Thank you very much. Would it be the intention then to, if this is approved, to monitor from the roads point of view, because it's really up to them? I've thought to monitor the car parking situation and the traffic flow through that part of town, because if residential streets are parked on both sides, then there could well be difficulties for bus services and or whatever. So are roads going to undertake to monitor that area should this be approved?
Thank you, Chair. Can I bring Fiona Stephen in, who was in our meeting with our roads colleagues this morning? She can provide an update. Thank you.
Thank you, Fiona. You're welcome.
Hello, I met with our roads department colleagues this morning, which was really helpful. So the person that I spoke to was Alistair Miller, and he said that they would indeed, if there were any issues occurring, they would respond supportively and make any interventions that they felt were necessary to help in terms of any increase in the flow of traffic. But overall, they were very much supportive of the mitigations that we've already discussed and looking to put in place.
Again, that's very helpful, Fiona. Thank you for that. So if we can get some sort of formal undertaking from our road service to monitor that area, should this be approved, that would go some way to actually making sure that any intervention that's required can be taken forward. And I'm sure local members will keep an eye on that too. I think that's very helpful, Fiona. Thank you for that. Thank you, Alex. Do you have any comment to make about the name?
I think the name is up for discussion, but I will defer to Lee if that's okay.
Mrs. Jolly, Lee.
I think I think the name is something that is probably coined locally. People refer it to the Banff or the Macduff Vaccination Centre because it's in Macduff. I don't think it's actually formally registered as the Macduff Vaccination Centre. So we can begin to change that narrative ourselves and in our communities. But I think we would be signposting vaccination centre to people as opposed to giving it a formal name. So I guess it's our story to change.
That's fine. Councillor Lang, are you content?
Yeah, I'm happy with that, yeah.
Okay, thank you very much. Councillor Grant, please. Murray.
Yeah, thank you, Chair. It was just a very simple question, picking up on 6.6 on page 108, where it mentioned that the building was previously surplus and only reopened for vaccination space on an agreed short-term basis. So I was just looking for information where it was located before, presumably at Chalmers, perhaps. Presumably it was, you know, the current space was used during pandemic times, but
it was at the Myres Community Centre.
Ah, okay, right. Yeah. Thank you.
Sorry, Alex. Okay, thank you for that. Councillor Keating, David, please.
Thanks very much, Anne. Well, I'm certainly going to be supporting this proposal because quite clearly medically it's the right thing to do. And that seems, I mean, infection control, all those other things, completely logical. I would, however, have some observations about the IIA because I think it's very important we do take account of the IIA in our decision making. And I know Alex made a noble attempt to identify some of these things, but let's be realistic. The responses we got represent 0.77% of the users of the vaccination centre. And despite what you said, Alex, that the questions did not say, there was no word positive included in the questions. It was either no impact, some impact, or a lot of impact. And I've obviously looked at different places from Councillor Cassie, because in both Aberdeenshire Council and Wikipedia, Banff is bigger than Macduff by 170 people. Let's, for the purposes of this conversation, say they're about the same size. And therefore I suggest that for everybody in Macduff who will be disadvantaged, and they will be people disadvantaged, there'll be an equivalent person in Banff who is advantaged. So it's a balance. And we weigh off this balance against the medical improvement and the clinical necessity of moving the centre. So I think that absolutely sways my view on it. The parking, I know I'm not meant to be operational. I don't do those things. But if somebody were to put some short-term parking at Chalmers Hospital for people who do want to just roll up, have an injection and then leave, that might mitigate some of the issues. But I am not here to fix those problems. I know that. The final point, and it is again in the IIAs, and it's the second IIA. It's the one that says no longer providing services in Macduff. Now, to me, that is an IIA about Macduff, but it refers in section 7 to Banff. And I just wonder if somebody's just copied across what was the previous IIA's section and put it into the Macduff one. Again, I think that's what's happened. I'm going to ignore it because what I would observe is the impact on the town centre of Macduff, if it's any, will be slightly less people coming into Macduff, which the current location doesn't look like it's particularly town centre-y, therefore I don't imagine there's a huge impact from that. So that was it, and I support the recommendations.
Thank you very much, and we won't invite Councillor Cassie back to argue about your numbers, but I'm sure it is fairly equal in size. Yeah, okay, thank you for that. Alex, would you like to pick up any of those points, please?
Thank you, Chair, and thank you, Councillor Keating. I think I would just go back to what I'd said in the introduction there, and I do take your point about, you know, the second IIA. I guess, you know, the issues identified, you know, in the survey did highlight concerns regarding the impacts of more services being delivered in Banff, you know, and again with the common theme relating to parking, etc., and access to Chalmers Hospital. But I get the way that the IIA is written, so I think maybe that is something we would reflect on going forward, and definitely take your comment on board, Councillor Keating. Thank you.
Oh, thank you. I think that it is really important. And it's, by the way, this is not something but you, Alex, because many of the IIAs we see seem to like to emphasize the negatives because they're real, but sometimes we don't always pick up that there are positives as well. So, but thank you for taking that on board.
Okay, thank you very much. I've got Keith Grant and then, Angela, did you want to come in on that particular point?
I did, yes, Chair, if that's
Please,
okay. Sorry,
yeah,
for
apologies, Keith, if you don't mind, yeah.
Thank you. Yes, it was just to confirm that although it may appear duplication, the responses to that second question in the IIA, that did reflect what respondents were answering in the question into that survey. So it's not actually duplication, but it was reflecting that respondents were generally reiterating concerns about no longer providing services from Macduff. And still making the point about concerns about providing services from BAMF. So we are reflecting what was came in response to the survey in that question. But I understand it may look like repetition, but just to provide clarification on that point.
Yeah, okay. Thank you for that, Angela. That's appreciated. Thank you. And thank you for waiting, Keith.
No, thank you. No, it's just variation on a theme of what's been spoken about. This is purely from a staff point of view that if we're moving clinic and we've spoken about parking and potential issues with residential parking, and the gut feeling is that in other areas in Grampian, when that happens, they put parking meters in because that's a deterrent and it actually backs the residents, but that could have a detrimental monetary effect on staff and indeed patients. It's just looking for assurance that people are not out of pocket for the clinic moving, because if the service is going to be expanded potentially, that could also conflict with other people parking for other clinics and people working, so there's just a bit of a mix. It's just a bit of assurance, please.
Alex, please.
Thank you, Sharon. Thank you, Keith. I do take your point, but I guess we're talking about 5 members of staff max that would move, and certainly, Steph, our lead nurse, is on the call, but we would definitely monitor that. Obviously, we wouldn't like our staff to be out of pocket, they need to come and be able to do their job. But I think together with the work that the hospital site will do around, monitoring that flow and making sure, that appointments, are scheduled properly, we would hope to mitigate against any impacts on staff. But I don't know if Steph, as our lead nurse, would wish to say anything. She might not, Chair, but I thought I will just check because it's her team that are moving.
Steph, you're most welcome, and if you'd wish to add anything.
Thanks, Chair. No, there's nothing else. I think, Alex, you've covered that in terms of the numbers of staff that we see within our team, and obviously we would not want any negative impact on our staff. So yes, we will continue to monitor that. Thank you.
Is that fine for you, Keith? Yep, okay. Thank you very much indeed, everyone. Thank you all very much for your questions and comments. Thank you also to all the officers who've responded. So if we can turn to the recommendations, we have the 2 recommendations on page 104. I haven't heard anyone with an alternative. So are we agreeing the recommendations as printed? That is agreed, and I do think we need to perhaps have an additional recommendation at 1.3, which would reflect the need to continually monitor the traffic flow on site and off site, and invite our roads colleagues to work with us in terms of identifying any mitigations that may be required in the future. But I do think that ongoing monitoring is really required to give that additional assurance in terms of the local situation. So if members are minded to accept that as an additional recommendation, that wouldn't necessarily be Health and Social Care Partnership colleagues, but I do think that needs to be something that we could work with our roads colleagues to do. Stephen, please.
Thank you, Chair. Yeah, I'm absolutely supportive of recommendations 1.1, 1.2. Supportive in principle of your recommendation, your additional recommendation 1.3. I suppose I'm slightly mindful about the language around continual or your sort of constant. Should the monitoring be on an ongoing, permanent basis, or is it for a period of time? Thanks.
Maybe some language problem there, Stephen. I don't really think that it would be, day to day for the next umpteen years sort of thing. But I do think there needs to be a monitoring programme, probably for 6 months, and then it comes back if there's any mitigations to be had. And that would see us over the summer plus into the autumn. And well, perhaps it might be for 12 months given the winter programmes of vaccinations. So I just think that would be, I'm happy to leave it to officers to determine the length of time that's required. But I do think that we need to put something in there to safeguard that particular part of the consequences. So I'm happy to leave it to my colleagues in terms of legal and governance with the wordsmithing, but just to give you some assurance, Stephen, that there'll be a limited period of time.
Thank you, Chair.
Okay?
Very helpful.
Okay,
as
thanks
always.
very much
Thank
for
you.
that. Thank you. So that is agreed with that additional recommendation, and we do need to monitor that parking situation and have any reports back that we need to consider. But I do think it's our roads colleagues, and if Mr. Miller's involved, that would be very helpful. Thank you for that. Takes us then to item 12, which is NHS Grampian as a population health organisation. This report's been put before us by Professor Parandothy, and we've been asked to consider and comment on the concept and model for the NHS as a population health organisation, and that's set out in Appendix 1, and to support the Health and Social Care Partnership officer participation in a community planning partners workshop to consider the relevant maturity matrix domains and identify learning to strengthen whole system partnership working, and also receive an update on the outcome of the workshop once an assessment has been completed. So, Professor Parandothy, Shantini, please, if you'd like to introduce your report. Thank you.
That's great. Thank you, Chair. So this item is being presented to the board today in response to the board's request in March for further information about the population health organisation approach. So this paper, the papers that you've got before you provides an overview of the concept of a population health organisation and outlines how this is being progressed in Grampian, recognising that improving population health can't be done by one organisation alone, but really does need a whole system approach. So for NHS Grampian, this reflects a shift from being a treatment-focused organisation to one that's centred on improving population health and well-being and working in partnership to prevent ill health, reduce inequalities and deliver more sustainable value-based care. This work connects with the work of the Health and Social Care Partnership, particularly in relation to how we work in partnership to use data across the system to plan services that meet population needs and deliver on prevention priorities. The paper also sets out the intention to work with partners to apply the Population Health Organisation Maturity Matrix through a workshop approach, so we can better understand our position and strengthen whole system working going forward. The plan is to work through the maturity matrix assessment with partners in community planning, including health and social care. As I said, this will be done in a workshop setting, and the learning from this will be used to understand our baseline position and how we can strengthen partnership working in relation to taking a whole system approach for community planning and health outcomes, so health and social care outcomes, particularly around preventing ill health. These findings will then be presented to the Integration Joint Board at a future development session, and hence, the ask of the board today is to consider and comment on the concept, support Health and Social Care Partnership officers' participation in the workshop, and then to receive an update on the workshop once the assessment is completed through a Chief Officer's report. Thank you.
Thank you very much indeed for that. And just invite members to ask any questions that they may have or make any observations, please. Colleagues, if you can indicate, I'll bring you in. Dr. Backwell, Colette, please.
Hi, thank you, Chair. I totally support the concept and the principles of this approach, but I do have one question which relates specifically to local authorities. The paper itself identifies on page 177 that local authorities have more influence over the determinants of health than probably most of the other partners. So my question really is, to what extent has Public Health Scotland engaged with the local authorities, and how are they being brought into this partnership approach?
Sorry, Shantini, please. Thank you.
Okay, thanks, Colette. So the whole concept of a population health organisation, that's part of Scottish Government's population health framework. So this is about how we deliver the population health framework to improve. Primarily it's to reduce that inequality in healthy life expectancy that we see, that we're seeing across Scotland. So you're absolutely right. Local authorities have got the levers, particularly around the wider determinants of health. And so this has all been discussed with COSLA. And locally, we work in partnership across the system. So through our Northeast Population Health Alliance, where we have discussed this, and this is why we want to do this maturity matrix as a whole system, because local authorities have a lot of the levers, but there is something about connectivity across the system as well. So some of our conversations really need to be, you're doing this, we're doing that, but actually what is it we're doing that's getting in the way, or what is it that we're not doing that actually might make it easier for what someone in another part of the system is trying to achieve. So I'll use the example of child poverty then, so I mean, something that people often say is, so what can the NHS possibly do about poverty or child poverty? But actually, if we're providing services, and we're providing services in a way that makes it inaccessible for people who are, don't have enough money to travel, or, work gets in the way of travel and so on, we need to make some adjustments around that. And so some of the work we're doing really in partnership with colleagues in local authorities is to really try and understand what are the things that we can do to make those services more accessible. So this is what I mean about, we need to improve our connections across the system. And we all have a part to play in that, and that's what this is about, really.
In terms of, you mentioned poverty, we've got a strategic partnership for tackling poverty and inequalities. So is it the intention to bring together the existing organisations and structures? We're not creating additional ones, are we?
There's no additional creation here. This is really simply about how do we make what we've got work better.
And where does the Northeast Public Health Alliance sit with all of this? Because if we're going to take this approach through community planning, which is, I think, what I'm reading, why are we persisting with a different organisation to do the similar work?
So we are taking this through the local, community planning type arrangements. The Northeast Population Health Alliance will be about synthesizing the learning. So how do we share the learning then across different places? So some of it is about that, but it really has to be about what are the things that we can do once for Grampian, and then what does that mean then in terms of needing to tailor it locally for local delivery?
Okay, I'll bring others in, Shantini, but I do have a concern that we are duplicating effort. If we're going to do it through community planning,
we're doing it through community planning,
then I'm not sure why we need some of the other organisational structures around that, because if we're going to do it once, then that's something I think we should follow through on. But happy to leave it with you. That's just a comment. Councillor Keating, David, please.
I'm going to add a few comments to your comments. And Santini, there's some really good points in here. I think suspending directed towards prevention, I think we'd all sign up for that, with the minor question of, and who's going to lose out by getting that redirection, which is something we all know we wrestle with. Empowering local teams, I really like that. But at the same time, we're going to address variations and remove the ones that don't add value, which will be a conflict. And they're both right in some respects, but that will be difficult to manage. And I do support this, population outcomes as well as simply performance management. Intellectually, that is correct. That's 5 or 10 years of cultural change for an organisation to accept that you're working your socks off, you're doing a great job, but the metric hasn't moved, therefore you need to do more. All of those are really difficult. And I worry that NHS Grampian is on level 4. I worry that we've just heard from Lee at a previous paper that, we are not even going to do something at enough speed because we're just running out. We're running at the margin of capacity. We're managing risk. And then I look at this and I hope it's not what's intended, but I read it very carefully and it's on page 172. It will enable the NHS to, I've taken a few words out there, tackle the root causes of health inequalities by addressing poverty, education, employment and housing while fostering community wealth building and inclusive economic growth. Well, that's the council out of a job. And I just think it's, the way you described it, Shantini, it was much more about, well, think about it, and that doesn't sound too bad. But as written, and I'm afraid words do have meaning here, and if some organisations read it, well, we now have to get, oh, by the way, net zero somewhere else as well. So it almost feels like every Scottish Government initiative has been piled into this, and, oh, the NHS will try and address it. And I think given NHS being on level 4, given the stretch, and by the way, I'm sure their managers are as stretched as our IJB managers, I just feel this looks like it's going to be too wide. Now, the ones I identified that I liked, actually, they will take 10 years. I really do believe they would take 10 years to do. And those ones I think have more immediate benefit to the health arena. So, and I guess the question, since we rehearsed it, your request at the request at 1.2, I'm going to ask the officers, do we have the capacity to go and support the multimodal workshop, whatever it was? And as I say, please don't hear this as me saying this is all rubbish, because it's not. There's things in there that I absolutely support and we should be doing, but I worry we're trying to do too much, and we need to skinny this down so that we can actually deliver some improvement in some of the areas that we could all agree on. I hope you don't find that to be too negative, Shantini. And also, I mean, I think the pictogram in 177, again, columns 2 to 5, I think, yeah, absolutely, go for it. Column 1, that refers to the bits I'm concerned about, which I think that's where net zero appeared. And I just don't see it. I'm not saying it's not important, but I don't think the NHS should be focusing on it. That was a bit long, but there you go.
Shantini, would you like to come in, and then I'll ask Lee about the capacity?
Thank you, Chair. So Thank you for those comments. I think they're all valid points, and I think some of this is in the interpretation. So take us back to Scottish Government policy or framework. This is something that's come through Public Health Scotland as well. So, but it is not. We need to take it and implement it locally in terms of what works for us, really. So I think the interpretation that I gave earlier around poverty, that is the reality of how it is going to work. The stuff around net zero and community well-being, that is in a framework for prevention. And actually, the NHS is an organisation that employs, is it nearly 18,000 people now? We, by being a real living wage organisation, we are making a difference. There are things that we can do for our workforce that actually does make a difference. It's about doing the things that we can do as an organisation and making sure we play or recognise what those wider determinants are in our day-to-day work. That's what that is about. It's not about us trying to do someone else's job, but it's about recognizing our role in how we can support someone else to do their job, so that collectively we have the right impact on the population. That's what this is about. It's, so this is in the spirit of how do we work better together? And that's what we're trying to do. Now, I do also take the point around too much too soon, but actually we've got to start somewhere. And this maturity matrix is giving us a baseline. Yeah. That's all we're trying to do now. Pretty high level. It sounds daunting, like a workshop, but actually we know there's a lot of work going on already. So what are the tweaks that we need to do to just make it that little bit better? Not all across, but let's choose the bits that we need to focus on, because that matters for us here in Aberdeenshire. Thank you.
Before Lee gets in to answer the question, so that's a really great clarification, Shantini, and we're actually having a discussion about this in IGB. That's rare, but I take your point about community wealth building, about an anchor organisation, about real living wage. I agree with all of that. That's what you are, and I think the concern I have is this is coming as things we need to do to change. I don't think you need to change. I think you just need to keep doing it. So therefore, I think the concern being if we dress all this up as, and here's something we'll do differently or more, it feels like it's coming down the road at you. Whereas if you just say, you're doing a good job, carry on, it doesn't almost need to be in here. It's just part of the day job, the same way as managing the staff is part of the day job. So I still have this concern that as written, this is just going to potentially have a negative effect. And I know it's not your intention. I absolutely understand that. And it's about improving. And some of the examples you gave about minor tweaks, I think we discussed it earlier at one of the other papers. I think it was the annual report, wasn't it? Incremental changes from where we are. Absolutely. This doesn't quite read that way, Shantini. That's the problem.
But yeah, I think we understand that it is about identifying what from this matrix, what is actually going to be important and prioritised, and that you would deliver. Because actually NHS as an organisation has got a duty to prevent homelessness. They have a duty in terms of child poverty. You have a duty to reduce your carbon emissions. So these are the duties that have been placed in public sector organisations to deliver for our national, priorities. So I'm taking it that you'll be pulling out, and you'll be making sure your duties are delivered. But also, as you say, and I take the point that, you will be, accredited as a living wage employer, and et cetera, et cetera. So I think your explanation has probably clarified a number of areas, but I'm sure that others will be the judge of that. So, but I will ask Lee if you'll come in terms of the capacity to support the workshop.
Yes, thank you. Can I make a very quick point before answering the question? Thank you, Chair. I guess I see this very simply, and that maybe is a reflection of my personality, is that this is about a matrix. This is about mapping out what are we already doing and where are the gaps, and enhancing how we join the dots between services. I don't see this as reinventing the wheel or imagining a whole new action plan and a whole load of new work. What I think is it gives us confidence in knowing ourselves and knowing what we do well, and then asking ourselves the question around if there are gaps, do we have the capacity to address those gaps? Which organisation, given we're doing it through a community partner planning lens, which organisation might take a lead on that and what supports might we give around it. But I think it has to be kept really, really simple and not seen as something huge that's out there that's going to come and change the world. It's about knowing ourselves, I think. In terms of the question around capacity, we already have a couple of officers around the community planning executive, and which includes our health improvement team, and they're also embedded in community planning groups. So there is already some capacity around this. We will not be adding to that. We'll be using those officers who are already well versed in this kind of work to contribute towards that matrix and the understanding and getting to know ourselves better.
Okay, we have existing capacity, not allocating any new capacity, and a combination of Shantini and yourself. This is about incremental improvement, knowing where we are and then seeing what we can incrementally improve, which I could not possibly take offence at. There we go.
Thank you very much, everyone, for getting us to that point. That's great. Much appreciated. Rachel, did you want to come in on those? You're happy to wait. So I'll take Councillor Grant Murray, please, then Dr. Backwell, then Dr. Tomlinson. Thank you.
Okay, thanks, Chair, and thanks, Shantini, for the paper. Very interesting read, and we can only agree, you know, as we've deliberated before, about the shift to prevention and early intervention and trying to tackle the root causes of health inequalities, poverty, etc. I mean, I think as it's inevitably the case, I mean, you know, many of the levers required to do this, especially that the health inequalities are perhaps out with the domain of the NHS and the council, and more reside in Edinburgh and London, so that there is necessarily a limit to what we can do, but a worthy goal nevertheless. And I appreciate it's a sort of very high level expository paper, but I was just wondering in terms of some of the terminology when you refer to a maturity matrix, could you perhaps explain just for my benefit who is you know, just what precisely you mean by that terminology? Thank you.
Okay, so the sorry, Chair, if it's okay to respond. So the maturity matrix is a tool that was developed by the King's Fund and Public Health Scotland. And so so as is set out in the paper, there are 6 domains to becoming a population health organisation. And so the maturity matrix then for each of those domains gets us to consider some things and assess whether we're at an emerging, established, leading, or sorry, there's like 4 levels, you know. So are you just starting out? Is this an emerging strength? Is this definitely a strength, or is this an established capability that we've got? So it's that kind of thing with some criteria. And so very much like what Lee has said, it's about just understanding where we are, and then, you know, what would the next step look like, and is that something that we might want to do because it's achievable, or is that not a priority for us? It's a tool, basically.
That's great, thank you. That makes a lot more sense now. Thank you.
Thank you very much. Dr. Backwell, Colette, please. You're on mute, Colette, sorry.
Thank you. I was just saying that the discussion has been really helpful, but I think it's important to remind ourselves that prevention and early intervention is one of the strategic priorities of this IJB and Health and Social Care Partnership. And this, I think Lee's sort of explanation about how the matrix might work was incredibly helpful. I think it's also important to note that this is a national initiative. COSLA have been involved, but there's no reference here as to what COSLA's view on it is. That would be helpful to understand. But it is an important part of how we start to move forward on the prevention and early intervention strategic priorities that we've set ourselves, and we mustn't forget that.
Again, thank you very much for that helpful reminder, Colette. COSLA have got 2 representatives on the board of Public Health Scotland, and I take it that's the interaction, Shantini, is it?
I think this was actually presented at a COSLA meeting, Chair, but I wouldn't know for sure. Well, I can find out if
No, that's fine, thank you. But certainly there are 2 members from COSLA, 2 councillor members who are on the board, the Public Health Scotland board. So there is a link back there. Yeah, that's fine, thank you. Dr. Tomlinson, John, please.
Okay, thank you. Just to say at the outset, I chair the Population Health Committee of NHS Grampian, so come at this with a supportive view. But as colleagues know around NHS Grampian, I'm always curious about, so what's the tangible thing that comes out of this? And one of the aspects of this is it is a national initiative. It's kind of top down. I have kind of queried population health organisation as opposed to population health system, because I think that's what it's about, and it's kind of dressed up in the partnership work. But I think I can see where you were saying, Shantini, that whilst it's coming through that kind of approach to the whole of Scotland, including us, but it's about what we need to do locally. And from that point of view, I think this conversation has been really helpful, because it's helped me understand a bit better just what we need to do specifically. And although we're following a national format for the matrix, what I would what's come to me through this conversation is it's not just about a tick box of we're here on emerging. Well, what does that mean? It's actually, where are we on some of these fundamental issues about prevention, as Colette's saying, shifting the balance of care, etc. So it's not going to be a bad thing to say very realistically where we are on that shift. And I would hope that officers, when they meet around this, around the community planning, take it in that spirit. And what I would like to see in due course is the tangible, where are we on that journey of prevention? And if it's not very far or it's further, can we have something specific around that coming out of this? And then it avoids being a tick box that we've done what we need to for a national initiative, to something, as you're saying, Shantini, what do we need to do locally and where are we on that? Thank you.
Come back, Shan.
Yeah, no, so yes, agree, John, and I think that's where we would need to get to. So I think this is all. I think we've got lots of dots, haven't we? And I think this is starting to join the dots up a little bit, because, you know, going back to the conversation we had earlier about the performance report, that's also about joining dots. So actually, I think, you know, I'm hoping that maybe sometime this time next year we'll be, you know, looking at how we're working slightly differently, and you'll start to see the threads across some of these things, would be my hope.
And members will be receive an update on the outcome of the workshop, so that will start to see that. Yeah. Thank you very much indeed, everyone, for all your comments and for officers' responses. And I will go back to Rachel before we finish. Poor Rachel's been sitting with her hand up for quite a long time. Rachel.
Yeah, thank you. And I suppose it's just to really say, and maybe reassure Councillor Keating, that I really welcome this, and actually, I suppose rather than seeing it as a kind of huge burden that's added to us, this is really embedding what we're trying to do already. And actually, I suppose the only danger is seeing it as a separate project. It's a fundamental change in mindset, and it's a demographic reality, and it's about how we're responding to it. And I think that working closely with Shantini actually delivered a speech on Monday just around our burden of disease and projection and how we need to shape our services responding to that. And I think that, along with this, is going to really help us in the future and how we shape our services and some of the decisions that we have to make as officers moving forward. So yeah, just support on my behalf. Thank you, Shantini.
Thank you very much indeed, Rachel, and I'm sure Councillor Keating will be assured. I didn't really want you to come back.
No, I know you didn't. I know you didn't. But I got a name check, Anne, so I'm allowed to come back in. No, look, I do take assurance, and again, the conversation's been really good, but we've also heard about the Hope Conference, which is also about decluttering, and I think there's many good things in this, and I'm absolutely on board that that's the sort of thing we want to do, and if this is the access to doing it, great, but I just want to make sure I think John kind of asked the so what question, and therefore I think that's it, we need an outcome, but that'd be great, and I take the assurance, I do thank you, take the assurance, Rachel.
Okay, thank you all very much indeed. And any decluttering would be most welcome, Shantini. I think that's the message, absolutely, from us all. Murray, is that a legacy hand from you?
No, I've got another question.
No, I had gone to recommendations, so very quickly.
No, that's okay. Don't.
No, very quickly.
No, it was just to approach things from a different angle, Shantini. I mean, you're looking at improving, the cooperation between the various organisations involved in public health. But what would you say are the barriers that exist at the moment that prevent that cooperation happening? Something on an everyday level currently. Is there anything specifically that comes to mind?
Be brief, please. Thank you.
Apologies.
Yeah, so I think there is a good level of working together. I think this is just about, well, so how do we enhance that? And I suppose, our findings from the doing the exercise will inform some of that, really. Okay.
No, I have one more attempt. So the recommendations on page 169, I think we've referred to those. Can we agree those recommendations, please? And we look forward to hearing more information after the workshop has taken place. Was that agreed? Agreed. Okay, thank you very much. And thank you, Shantini, for your report. And as I say, we wish you well in your efforts to declutter. So there we go. Thank you very much indeed, and we do look forward to hearing more of the work that you're taking forward. So that takes us then to item 13, which is hosted services and service level agreements. This has been trailed to members through a development session previously, and this is the report here to consider the recommendations to approve the implementation of the service level agreements, which are in appendices 1 to 13. We've been asked to defer a decision on proposed reporting arrangements, which have been detailed within the report, until the IJB meeting on the 18th of November, which will allow time for provision and consideration of baseline performance reports, and to approve the approach to service improvement and transformation and to the activity, which is detailed in paragraph 4.10 of the report. So can we have a brief introduction, please, Shona? As I say, members have been able to consider this previously in an informal session, but I'd also like, just before you come in, Shona, to welcome those colleagues who have joined us for this report. Shona, thank you.
Thank you, Chair. Members, I'm pleased to introduce a report on hosted services and the development of service level agreements, which represents an important step forward in strengthening how we oversee and assure these services across Grampian. My colleagues Alison MacLeod and Sandy Reid from Aberdeen City Health and Social Care Partnership are also in attendance for this item. My colleagues were unfortunately unable to attend on this occasion because of other commitments. As members will be aware, the 3 integration joint boards collectively hold responsibility for the strategic planning of a number of Grampian-wide hosted services, with operational delivery delegated to a single host partnership. As such, this report has also been considered by Moray Integration Joint Board on the 25th of June and Aberdeen City Integration Joint Board on the 30th of June. The arrangements for hosting services have developed over time and are based on practical factors such as geography, efficiency, and the need to sustain specialist provision across the Grampian area. However, while these arrangements support effective service delivery, they also present challenges in ensuring consistent assurance, visibility, and governance across all 3 partnerships. The report responds directly to an internal audit recommendation following an assurance review of IGB hosted services, which formed part of the internal audit plan for Aberdeen City IGB in 2024. The review highlighted the need for a more consistent and robust approach to how performance and transformation of hosted services is monitored and reported to boards. In response, the key proposal before members is the introduction of a suite of service level agreements covering each of the hosted services. The SLAs set out clear expectations for service delivery, defined performance and financial metrics, arrangements for reporting and accountability, and a structured approach to service improvement and transformation. Importantly, they're intended to provide a more transparent and consistent framework for assurance, enabling the IJB to have clearer oversight of both operational performance and future service development. The report outlines a proposed proportionate risk-based approach to reporting, recognising that these services vary significantly in scale and complexity. And as the Chair has noted, it is recommended that members defer a final decision on reporting arrangements until November 2026 to allow for us to provide baseline performance information for financial year 25-26 to be considered in the context of the board's risk appetite. Alongside this, the paper sets out a structured approach to service change, ensuring that any future developments are data-led, agreed collaboratively across the partnerships, and aligned with national guidance, including requirements for engagement with people in communities where appropriate. It is proposed that service improvement activity, which is more operational in nature, can be agreed by the 3 partnership leadership teams and reported to the integration joint boards with scheduled performance reports. With strategic change requiring the approval of the 3 boards, with the approach guided by Healthcare Improvement Scotland Planning with People guidance. So in summary, members are asked to approve the implementation of the service level agreements, approve the proposed approach to service improvement and transformation, but to defer a decision on detailed reporting arrangements until November. I'm happy to take any questions along with colleagues.
Shona, thank you very much indeed, and thanks to colleagues who again have joined us and have participated in the preparation of this report. So thank you for that. Stephen, please.
Thank you, Chair. Mine is predominantly a comment, welcoming this report and the bundle of appendices that go alongside it. As Chair had indicated, certainly Aberdeenshire Integration Joint Board had the opportunity to discuss this in development session. So I'd like to particularly thank Shona and our colleagues for the significant work done to revise the content or update the content of this report to reflect the discussions that we had in development session. I find that particularly welcome. And I suppose the only other comment I would make is that in terms of the risks that are identified and the recommendations from the internal audit, it makes absolute sense that we should be producing service level agreements. However, the risk and the lens of the risk that is being considered still feels pretty financial. And as I said in the development section, there are the other risks. There are clinical and care delivery risks, which I know that officers are very well aware of, but wouldn't want only financial risks to be heard during this public meeting of the Integration Joint Board. Thank you very much, colleagues.
No, again, very helpful intervention. Thank you very much indeed. And I'm sure if you would have any concerns, you would call these areas of work in to your clinical governance considerations through our subcommittee. So really helpful intervention. So thank you indeed for that, Stephen. Shona, do you want to respond to anything there, or are you content? content. Okay, thank you very much. Dr. Tomlinson, John, please.
Yeah, thank you. And thank you for the report. And obviously it's a significant amount of work that's gone in across the IJBs to get to this point. But it is an essential point that we get to in terms of governance across these services. My question is, paragraph 4.10, there's reference to minor or major service change. And then in paragraph 4.11, there's reference to operational service change, which will be done through the officers, but strategic service change, which will come to the IJB for decision. Well, is that just wording that cross-references? Is minor the same as operational and major the same as strategic, or is there a difference there?
Thank you, John. Yeah, I think I could possibly have worded this better in the report to make that clearer. So what we are proposing is that we will take the same approach to service improvement and transformation as we would for all of the services that are delegated to the boards, with decisions taken at the appropriate level of the organisation according to the scale, complexity and the strategic impact of the proposed change. I guess the main difference here is that we will need to either inform or seek approval across 3 partnerships rather than just the one in relation to these services. So the IJBs will be informed of more significant operational changes and have oversight of their impact through scheduled performance reports, and strategic changes will require approval from the IJBs in line with our current arrangements. The Healthcare Improvement Scotland description of major and minor service change serves to guide our approach to how we engage and involve local communities in the decisions that affect them, rather than determining whether or not we would be seeking approval from the IJB for a proposal or recommendation. So it sits alongside that, but we would follow our usual arrangements around operational and strategic decision making.
So those don't cross-reference?
They don't directly correlate,
yeah,
no.
That's fine. And is the understanding around what strategic service change means in terms of what comes to the IJBs probably shared across the chief officers, across the IJBs?
I think that's a good question that I'm not sure I'm best placed to answer, but I mean, I would anticipate that any proposed service changes would be discussed by the 3 chief officers prior to taking those forward to the appropriate body.
Okay, that gives assurance that Lee would be involved in that. Thank you.
Thank you very much indeed. Councillor Keating. David, please.
Thanks very much, Anne. I absolutely think we need SLAs, and I think this is using a standard framework, which I think is very sensible. So a few general points first. The Moray SLAs actually say they include term. I don't think anybody else's do. But that said, should we have a term for everyone? And the inclusion, and I think Stephen mentioned it, the inclusion of budget numbers in some of them and staff numbers, does that mean we're intending to sign these every year? Because to me, an SLA should be an evergreen document. So I'm just questioning what's the intent there. Very much I picked up the same thing as the Vice Chair, John, on transformation. And I read the SLAs, and that seemed to say that a major service change as defined by HIS would be the only ones that came to the IJBs for consideration. Now, that's why I read them. And if that is the intent, does that give us enough sight in advance of enough changes? And I don't know an answer to that because I don't actually know what the HIS definition is. But I'm thinking of a few things that have arrived on our desks after they've been decided, and we've all gone, didn't you think you might talk to us about that first? So I just don't know, is that the appropriate level? And again, I have it as a question. There does seem to be a lot of the data points. A lot of the things in the performance management are data points. Data points are lovely. I do like targets that you can actually measure. So it's just a question for the officers to consider. And then 4 of the SLAs, mental health, heart failure, diabetic eye, and HMP, seem to have multiple escalation routes for clinical risk. So is it clear that some go one way and some go the other, or do we actually have the same risk going to 2 different bodies? Question. I do believe in single points, but there you go. You can tell me what the actual intent is. And then I've only got 2 on the detailed. I have got more. I've sent them to the officers. You can take them on board or not as you wish. But the 2 is on Appendix 6, which is the bladder and bowel. They've included a bit about what best practice might look like. Well, that's interesting, but if we've given them, what are we asking them to do rather than what might they like to do? Because I'm sure all of us could think of better things, and more improvements we could make. And then on the GMED one, there isn't a performance metric on changing the mix of the staff, which I think we've rehearsed in this room before, which is to try and move from bank staff to staff GPs. And if that is an intent, if it is, then I think we should have that as a KPI. But apart from that, I do appreciate the provision of the documents, which we didn't see at the development session. So this is the first time I've actually seen them, and they are good. And those are my observations on them. Thank you.
Thank you, David. So I'll try and take each of your questions in turn. So certainly the intention is for the SLAs to be rolling documents, so that they wouldn't be for a fixed term unless there were any significant changes, and then they would be brought back for approval. So there is the intention for those to be rolling documents. In terms of the Healthcare Improvement Scotland guidance and that's impact on IGB decision making, just refer back to my response to John that we wouldn't be using that as an assessment of whether a matter should come to the Integration Joint Board or not. In general, we try to take decisions at the appropriate level of the organisation according to the complexity, the scale of the change, and we're making those decisions every day and making those in the right forum. To me, the SLAs will actually reduce the risk to the Integration Joint Board of something coming at the board out of left field, because it makes very clear the expectation that the board will have oversight of changes and indeed approve changes that are proposed that are of a more significant strategic level. In relation to the bladder and bowel service, yes, note that we've included in the service level agreement the sort of gold standard for the service against the standard that we're actually able to provide with the funding that we have with the budget that's available at the moment. We've developed these service level agreements with services, and we wanted to be very transparent about what national standards might say should be expected against what they're actually able to provide. I will take the board's guidance on whether we should retain that within the service level agreement or whether we should bring that through in performance reporting once we agree how that will shape up. And then lastly, I think your question in relation to GMED, I did have the opportunity to discuss this with my colleagues in Moray. Their intent, it's certainly their intent to move towards employed staff rather than bank staff, and they will look to include that in the performance report later this year.
I'll just come back in a couple, Shona. Thank you for those answers. I think bladder and bowel are the only one who's put in that they don't say gold, well, they just call it best practice. So the other 12 don't have best practice in them. And to my eyes, to be honest, this is an SLA. So this is what we're asking them to deliver. So my personal view, and it's mine, is best practice. By all means, bring it back in the papers or through the various committees or subcommittees, but I don't think it should be in the SLA because it's not what we're asking them to do. That's my personal view. And the final one is on transformation. So your answer to John gave me some assurance, and as you described it now, seems good. I just read the section 5 in every one of the SLAs, and it reads very, very much as though, and I'll read it, major transformation using the Health Care Improvement Scotland definition of major service change will be presented to the 3 IGBs for approval. It looks very much from the wording in all these documents that that is what's intended. If it's not what's intended, could I encourage you to go and have a read of section 5 again?
I do think we're maybe getting a bit, we're diving a wee bit too deep, but anyway, Shona?
Yeah, no, happy to take that comment on board, and I will work with my colleagues in City and Moray to reword that section to make sure that it accurately reflects how we'll be working.
In answer to your question about whether or not something should be included in performance, I think it should, rather than anywhere else. Yeah, okay, fine. Do members of the board agree that that should be reworked? Because, you know, David's made the comment, Shona, you've responded that you'll change it, but are members of the board minded to support that change? I'll take silence as an agreement. Because again, I think we need to make sure these are board decisions, not, yeah, okay. Well, just, okay, so again, Shona, if board are minded to accept that, there would be a change, that's fine. I'll move now. Dr. Thompson, John, please.
Yes, just on that point, I do think that that transformation activity, the description there, is in need of that clarification across the three IJBs, because I think their understanding of transformation is different from what you've described and what Lee has thought of, and it is a very important piece in terms of governance. So I think if that can be clarified, that would be helpful. Thanks.
I'm going to invite Lee in on that last point, please. One we've just discussed.
Thank you. I suppose my query is that so we've had some feedback around the wording, and Shona very kindly has made an offer to change something to make that clearer. I guess my question is, if we're going to change something, for what end? Because are you asking as an IGB, therefore, for us to bring a report back with changed wording in it? Or particularly, I'm thinking if you're agreeing the recommendations, I know we haven't got to that point yet, or is this feedback to officers saying, I think possibly in the future, when you bring future reports, you could word those bits a little bit clearer and differently, so that it tells the story that that it needs to tell, as opposed to what's clearly caused a little bit of confusion. So I just want to double check what it is we're agreeing to do, given the willingness of my officers to take changes and to take comments on board. Thank you.
I think from my point of view, what we're not asking you to do is bring a report back. So that's why I was, sorry, Lauren, yeah, I'll just come back to you, but I just think that where we've got suggestions or comments or whatever, we can't just automatically say we're going to change it because of the consequences. So Lauren, please.
One of the potential options that the IGB could consider is a delegation to the Chief Officer following consultation with the Chair and Vice Chair to deal with that.
I think that's helpful. If it is the intention of the board to have those changes made. I'll bring you back, David.
I'm going to... Lauren has said what I was about to say, which is I absolutely have no interest in another report coming back. I want them signed. They're not signed yet. Here's some suggestions. Delegate it to the officers very kindly. And I don't want to create more work, really. I don't. To take them on board, the comments, and either take them on board or discard them as you wish.
Okay, thank you for that. That's helpful. But I just think going forward, we need to have board decisions, not just, you know, changing. But that's fine for the delegation. We can add that in at the end. John, you want to come back?
Okay, just I understand this is going through three IJBs and therefore it's been through two, so there's a complication. All I'm wanting is to make sure that an understanding of what transformation is shared across those three IJBs, three health and social care partnerships. So happy for officers to do what they need in terms of signing this off, as long as there is that other piece of work that's undertaken. Thank you.
Okay, thank you for that, John. Murray, please. I'm losing track here.
Sorry. Thanks, Chair, and thanks for the report. It's good to see all the detail contained in these SLAs, and I look forward to seeing the proposed performance reporting arrangements in November, as promised. And my query was just precisely on the item 5 transformation activities as well, and sort of just to reiterate what's been mentioned. So minor transformation would be looked at a local SLT level, and major requiring agreement of all three IGB. So I'm just approaching it from a slightly different aspect, and it's probably an entirely hypothetical one, perhaps, or not one that's necessarily going to be happening in reality. But it was just about the governance consequences here. If there's disagreement between the three IGBs and major transformation, if there's not unanimity, does that mean that major transformation is stymied and won't go ahead? Has that been, and has that scenario been entertained yet? Thanks.
I actually think that's always a risk that we have when we're working across 3 IJB areas, and it's something that we've never come to yet. But if it was something that we would obviously negotiate and work our way through with the other partnerships as much as we possibly could until we got to an outcome. I think that actually what we've got is a huge step forward in terms of actually having these service level agreements that we can work with. So I think it's a great place to work from going forward.
Thanks, Lauren. I agree. It was just something on reading the paper that occurred to me as a potential hypothetical, but thank you.
Thank you very much indeed. I don't see any other indications, and I just would like to agree with that last point that this is a huge step forward. We have been discussing this locally and also within the Cross Grampian Chairs and Vice Chairs group for some time, so this is really welcome. And I would just like to thank all representatives from the 3 partnerships for all the work that's gone into this to get us to this point. It really is very welcome, and it's much appreciated, the work that you've all done to get us to this point. So can I take you then to the recommendations again? I have referred to them previously. But I would like to add an additional recommendation at 1.4 that should there be any proposed changes to the service level agreements and or the wording around that, then that would be delegated to the Chief Officer in consultation with Chair and Vice Chair. And so with that addition, can we agree the recommendations, please? And that's agreed. Thank you very much. Thank you, colleagues. That does bring us to the end of our public session. I confirm that the public items have now been concluded and the recording will be stopped. I would like to thank you for your interest in this business, and we'll now stop for a short moment to pause recording, and we'll move into private session. Thank you very much for your attention.